Hello, good morning, everyone. Welcome to this week episode of Breakfast at UMHealth. And today we are privileged to listen to one of the presenter from our department, obstetric and gynecology, uh, talking about how we treat patient with infections, fertility patient with infection, and how we don't actually prejudice and treat them equally. So with us today, we're going to listen to one of our newer specialists and lecturer in the department, Dr. Nabila Arfah, who is graduated in from Monash universities and had the Masters of Obstetric and Gynecology uh, about 3 years ago, and now she has a special interest in infertility. So let's listen to her case presentation and also discussion about this for the next half an hour. Over to you, Nabila.
Thank you, Prof. Assalamualaikum and good morning, everyone. I'm Nabila from the ONG department. Today, I would like to talk about something many of us encounter in our daily practice, but may feel uncertain about. That is, infections in patients undergoing fertility treatment. This talk is not about rare conditions or lab theory. It is about our real patients, real dilemmas, and how replacing fear with evidence leads to better and fairer care. Let me start with a real case at our center. Madam Z is a 41.
Nabila, we can't see your slide. Can you share the slide?
Let me start with a real case at our center. So Madam Z is a 41-year-old woman, para-0 with 2 first-trimester miscarriages, who has been married for the past 5 years. Her workup showed low AMH, her husband had teratozospermia, so they needed fertility treatment. Routine screening revealed that she is a chronic hepatitis B carrier. Everything else, HIV, hepatitis C, syphilis, were negative. So this is a situation many of us will face, often unexpectedly, especially during routine screening. This is where the discomfort often starts. Questions can come up, sometimes spoken aloud, sometimes unspoken. Is it ethical for us to help them conceive? Won't the baby be infected? Are we putting our own staff at risk? In this case, the outcome was positive. Referral to the infectious disease team was made, co-managed, and tenofovir was initiated. The patient proceeded safely with assisted reproductive technology treatment at our center. But not all patients get this far. Many are stopped earlier because of fear rather than facts. According to the WHO, in 2023, 1 in 6 couples experience infertility, and many of them live with infections, HIV, hepatitis B, tuberculosis, for example. So there are persistent misconceptions that ART is unsafe, transmission risk is high, or that staff are endangered. According to the European Society of Reproductive Health, they have guidelines that provide evidence-based recommendations on managing patients with viral infections, including HIV, hepatitis, in ART settings, which emphasizes on risk reduction rather than exclusion of the patients. The American Society for Reproductive Medicine also states that ART should not be withheld from individuals with chronic infections and provides recommendations to minimize transmission risk during fertility treatment. In reality, ART today is safe, ethical, and evidence-based even in the presence of infection. So these patients, they don't only appear in the fertility clinics. They can present to our emergency departments, medical wards, primary care, or infectious disease clinics. ART is time-sensitive. Decisions made outside of our unit, such as delaying referral, giving incorrect advice, can permanently affect outcomes for these patients. That is why it's important for this topic to all clinicians, not just to the fertility specialists. So who are these ART patients? Having said that, these patients are not special cases or morally different patients. They are medically normal individuals who undergoes the structured treatment. Care should always be evidence-based, respectful, and non-judgmental, because when patients feel judged, they disclose less, and that actually increases risk for everyone. By the end of this session, I hope you'll be more comfortable in identifying infections relevant, understanding how they affect fertility and safety, and recognizing your role, even if you're not in a reproductive unit, in supporting safe and ethical care. So, how does infection affect fertility? Infection can affect fertility directly. For example, chlamydia or tuberculosis can cause tubal damage, or HIV affects ovarian and testicular function. So, according to Sharma, JB, genital tuberculosis, especially in high TB burden regions, can cause direct endosalpingitis, fibrosis, and tubal occlusion, which is a major cause of infertility. They can also have indirect effects such as systemic illness, medication side effects, and psychosocial impact. Stigma alone can delay presentation for years. So, in ART, timing is everything. Why does this matter? Because infection, they can affect oocyte quality, endometrial receptivity, and inflammation and implantation. Fever and inflammation can disrupt hormonal balance and the implantation window. According to Chuang et al., they have stated that higher levels of pro-inflammatory cytokines are associated with lower implantation rates in ART cycles. Some infections also carry maternal risks or laboratory contamination risks, but these need management, not avoidance. When does infection occurs in ART? The risk profile changes depending on the ART stage. There are ovarian stimulation, oocyte retrieval, embryo transfer, or early pregnancy. So these are the different stages in a fertility treatment. This is why blanket rules do not work for these patients. Decisions must be stage specific and individualized. Each infection matters for different reasons. For example, HIV raises concerns about transmission and viral control. Hepatitis B and hepatitis C raise laboratory safety issues. Tuberculosis affects the endometrium and tubes. HPV affects a woman's cervical health. COVID raises timing and safety concerns. So moving on, what are the evidence on HIV and in ART? With undetectable viral load, U equals to U. Undetectable equals to untransmittable. Therefore, sexual transmission is essentially zero. ART transmission risk is also extremely low. Options like wash sperm and IVF or ICSI are safe, and pregnancy outcomes are comparable to non-HIV patients. What about hepatitis? Hepatitis B and C? The risks here are well understood. Possible lab cross-contamination and vertical transmission. Nonetheless, mitigation strategies exist. Separate lab workflows, dedicated storage, and neonatal immunoprophylaxis. Importantly, ART is not contraindicated in these patients. Moving on to tuberculosis. Genital tuberculosis is often silent and devastating to fertility. Tuber blockage and a thin non-receptive endometrium are common. Many of these patients, for many of them, IVF is the only option, but of course, treatment for tuberculosis must come first. What about laboratory safety in ART? ART labs follows universal precautions, closed vitrification systems, and cryostorage segregation. Protecting our staff is important, yes, but it does not require excluding our patients. Infection control is not discrimination. So there are actually myths about these patients that are not factual. For example, ART patients are immunocompromised is a myth. Most are immunologically normal. Any infection cancels ART. Well, that is true. That is not true because it depends on severity and stage. And that has to be looked into, not a blanket rule. Another myth would be ART is elective. It is in fact not, because timing can be critical, because for these women, their biological clock is ticking. Moving on, there is also a persistent myth that ART exposes staff to unusually high risk infection. In reality, the risk is comparable to or lower than routine procedures like blood taking. There are no documented cases of ART-related staff seroconversion when the SOPs are followed. What about vertical transmission and neonatal outcomes? With optimal care, transmission rates are actually low. HIV has around 1%, hepatitis B around 5%, with immunoprophylaxis, and hepatitis C around 5 to 6%. ART does not increase the risk of vertical transmission. What about ethical and legal considerations? Reproductive autonomy is a fundamental right for everyone. Denying ART purely based on infection status violates principles of justice and non-maleficence. So, we have all heard statements like, why risk a child, or better not to offer ART for them. The response is wrong, and it must be evidence-based, calm, and multidisciplinary. Fear should never be the basis of our clinical decisions. What is the role of non-ART clinicians? So even if you never work or is not working in the reproductive or ONG department, your role matters. Early referral, accurate information, stigma reduction, and advocacy make a real difference for your patients. What are the roles of other departments? Primary care and medical teams optimize chronic infections and vaccination. The infectious disease team can manage viral suppression and more complex cases. Emergency and surgical teams need awareness of recent ART procedures. This is truly empty care. So, who decides whether the patient can go through treatment? Not one clinician decides alone. The treating doctor manages the acute issue. The ART or fertility team will assess the cycle-specific risks. The decision is joint, it is individualized, and it should be MDT-based. What do clinicians should do or don'ts to avoid? So clinicians should treat infections promptly, communicate early, document clearly, and reassure honestly to the patient. What we should not do, we should avoid unilateral cancellation, judgmental language, or assumptions about our patients' fertility choices. Now, let's go back to Madam Z. Madam Z proceeded with IVF after appropriate treatment and precautions. However, the pregnancy ended in a miscarriage, which is unrelated to hepatitis B. But the key point here is this: she was given a chance safely and ethically. So, this case shows that infection is a variable to manage, but not a reason for us to deny care. Replacing fear with facts delivers reproductive justice for our patients. So, my take home message for today is infections are not contraindications to ART. Shared, non judgmental, and evidence based care improves outcomes, and prejudice will only harm our patients more than infections ever will. From fear to facts to fair care, patients with infections deserve the same chance at parenthood. Before we conclude, I would like to announce the launch of a new integrated clinic between the ONG and infectious disease departments. This multidisciplinary service is designed to streamline care for patients with complex needs. So the clinic will run one Friday morning in each month. We will be accepting referrals for various gynecology conditions such as abnormal uterine bleeding, fertility consultations, menopausal health, and contraceptive advice. This clinic is led by Dr. Yogita, our very own ONG specialist. So please direct your referrals to her attention, and we believe this collaboration will significantly improve patient outcomes by providing holistic one-stop care. With that, thank you everyone for tuning in.
Thank you, Nabila, for your insightful presentation. So I think it's a lot of time still for Q&A session. And for those who are have a lot of any question, we probably can write down at the chat bottom there, or Q&A, so that I can read out and answer the question. So can you please unshare your screen, Bila? Okay. So so back to Madam Z. Um, can you tell us how the infection was actually detected? What is the routine investigation that we do in a fertility clinic in all fertility couple?
So in all fertility couples, thank you, Prof, for the question. So for all infertility couples, we will do a basic screening to screen for infective diseases such as HIV, hepatitis B and C, and also syphilis. So for her case, she presented to our ED. Actually for miscarriage for her previous pregnancy, and then after that she was given a date to come to us to our fertility clinic. So when she was in our clinic, we did the screening and detected that she has got hepatitis B with high viral load. Therefore, we have referred her to the infectious disease team and co-managed with infectious disease team and given treatment of tenofovir before starting our fertility treatment.
Okay, thank you. So I think it's important to inform all the audience here that uh, it is a routine, even though there is asymptomatic or low risk patient, that we screen HIV, hepatitis B, C, and VDRL to ensure the safety of the patient and the other patient who have been treating in the fertility, and also us as the staff. But of course there is no prejudice for that. So how do you ensure that the patient who are infective not to get transmit the infection to other patients samples, or the treatment that they actually took in the fertility clinic?
So usually, for our staff and for everyone else, we will have safety precautions during our fertility treatment and for every procedures that we have done. And for their after their oocyte has been retrieved, actually we have a separate pathway for their storage of their fertility for their gametes and oocytes to be stored, and it is not together with the other patients. It is stored separately, and we have a pathway for that.
Okay, thank you. So, I think for IUI, which we have a disposable kit for patient with IUI, because they don't actually need a lot of media or kit for IUI. So we use a disposable kit. And as you know, Nabila, that we also have infective lab now, meaning that we have separate lab for IVF and IUI, so that we protect the other patients. And of course, we already stored all the embryos and oocyte from an infected patient in a separate tank. Okay,
Okay.
that's good. So there is one question here. It will ask about the service question. May I ask whether the step of measures being taken to reduce stigma amongst the healthcare providers within the department. So among rotating medical officers, nurses, PPKs, so they have a lot of stigma to actually treat or handle patient with infective. Of course, in ID ward, I don't think there's any issue, but this is outside the ID department or medical department, where as us as gynecologists, infertility unit. So how are we going to improve this awareness?
Yes, I believe this is very important because they are the people who will actually see the patients first when patients come to us. So I think we need to have more continuous medical education or nursing education to our nurses and our staffs, and make them more aware of this situation. We need to educate them by conducting more sessions, I believe. such as what we are having today, to make sure that they are aware of the condition, and also to reduce stigma among us, the healthcare providers.
Okay, that's great. I mean, we have to do more and more education. I think within our department also, we have actually asked ID to explain to us about how it won't transmit or affect them by handling and such patients. So I think it has create a lot of awareness. So with regards to the clinics that we have the collaboration. So um how is it going to be conducted there? So is it together in the same clinic or a separate clinic?
Yes, it will be done as a conjoined clinic together with the ONG specialist and also the ID physician once a month in the ID clinic on Friday mornings. So yeah, we will sit together, the ONG specialist and also the ID physician. Then we will see the patients together. And if any referral can be made to us, and we will slot in the patient to the slots.
Oh yes. Thank you. Yes, this is actually been happening before, but it's not formalized because, as you know, that HIV needs HIV patient needs regular cervical surveillance because they are immunocompromised, so they are at risk of getting HPV infection. So, we are doing it, but it's actually extended to those who are need fertility treatment. So I think it's a good avenue for everyone to have this collaboration and aware about this. Can you tell us where the fertility unit are located in our department, Nabila,
Okay, so
and
in
how
our
should we refer? How can they refer to us?
so in our unit, it is located at level 4 in Complex Wanita Kanak-Kanak. So referrals can be made, either can just call any of the specialists on during on call, or can just write a referral to the clinic, and patients can walk into the clinic, and we will be screening the referrals accordingly and give timing for the appointments for the patients.
Okay, that's great. I mean, so for fertility in the UK, where they only have a few centers that offer fertility patient treatment because they need a special lab. So we are one of the I mean the lab in Malaysia that offers fertility unit for this. So thank you very much, and we hope that we can get more referral, better awareness on this patient. So, any okay, there's one. Is there any question? What is the okay? So how about there's one more last question. What are the strategy to reduce stigma among the couple? Just now you are mentioning about among um the the medical staff. So how about reducing the stigma to get fertility treatment among the couple?
Okay, so this is something that is very personal and private, and couples should be handled sensitively, as we know. So it is again back to our part. We have to educate ourselves to first reduce our own stigma, then only we can be able to interact with the couple non-judgmentally. So if us ourselves are having all these perceptions and judgmental, so it can be quite difficult. So we have to educate ourselves first, then only we will be able to handle couples with infections. And I believe they have to know that they have the option, and they are not judged by us.
Okay, I think it is a very good session so that we all know about how we treat non-prejudicely for this patient, because we are one of the best center for HIV and infection. So we shouldn't actually tell them that we are not able to treat them
Treat them.
in a fertility. So I think with this initiative, we hope that we can treat more patients without prejudice. We have a special lab for this, and hopefully that we can get more patients and couples to explore their possibility of ART in UMMC. So I think we are already near the time. So any last word, Nabila, before we end?
So if you see any patients with infection, please don't judge them. Please help them and refer them to us if they need any treatment. Thank you.
Okay, okay. Thank you very much. And over to the next speaker. Uh, Thank you very much, and hopefully to see you again. Thank you.
Thank you, Prof. Thank you, everyone.